before we post it if you wish. So with that, we might move straight into it. Karen, if that's okay with you. Karen, thank you very much for joining us. Dr. Karen Keang is a general paediatrician in Melbourne with a particular interest in equity and access issues for vulnerable children and their families, and how climate change and environmental degradation significantly worsens equity gaps. She works at the Royal Children's Hospital through the Victorian Virtual ED and in the community outpatient setting, and in her spare time is actively involved with Doctors for the Environment Australia and spearheading healthcare sustainability efforts at her hospital. I think Karen's going to talk to us today about virtual consulting.
Yes, and virtual ED. Thank you. Thank you, Michael. So I will, exactly. I have been involved particularly with virtual ED, which many of you may or may not know about. That is in Victoria. And so I was sort of asked to talk a little bit about telehealth and some of my work with virtual ED, and that it really provides a lot of those sustainability benefits, not just the social, financial, and particularly its environmental savings. So this is going to be quite an informal talk. I've just kind of come out of the resuscitation room in the ED, so I'm a little bit like this. So I apologize if I talk a mile a minute, and I'm very happy to field questions throughout, during, and afterwards. So let me see if I can. Are you guys seeing that now? Yeah? All right. So let's see if I can make it move. How do I make it move here? All right. So just briefly, so telemedicine, in my literature search in preparation for this talk, and probably some research in this in the future, I found that telemedicine is like being used in every area of medicine now. It really obviously took off with COVID when no one could do sort of face-to-face appointments. And it is used particularly for delivery of care, for evaluation of care, for lots of educational programs. You can see some nurse-led interventions, remote EDs, a lot of mental health is being done through telehealth, during telehealth and screens. Surgical stuff, particularly post-operative reviews for patients, often are being done on virtual. A lot of monitoring, so type 1 diabetes in pregnancy. A lot of this is being aided by some of the other remote equipment that's being that we can deliver to families now. So a lot of families now have like pulse oximeters at home. A lot of us have like our watches that are taking our heart rates and things like that. So there's a lot of, if we can get some equipment to people at home, we can do a lot of in-home monitoring as well. So I'm looking at telehealth, telemedicine as a new model for patient care, but it needs to confer equivalent or added convenience, cost, and clinical effectiveness when compared to the standard of care, which is the in-person visits. These benefits should exist for both patient and provider. So just to show you a few things, so characteristics of telehealth, it can be either patient and clinician having an appointment or a consultation. It can also be a clinician to clinician. And I've actually given you a picture here. This is when I was in Alice Springs, and we were in Alice, and we were consulting out. This is a baby on the screen, and they're trying to, this is out in a remote community, and the pediatrician here is kind of advising those nurses and doctors out in remote community on what to do next, just by looking at that. So that's clinician to clinician. It can be either synchronous, which is real time interactions, or it can be asynchronous now. In the US, they were having of visits where a patient could type in their symptoms and answer a questionnaire, and then a GP would review that and then get back to them. So that's asynchronous, and that was being, that was Medicare billable in the US at that time. And the media, video, telephone, or text message. But there's, a number of barriers to delivering telemedicine. So many people lack the tech infrastructure and stable internet. I'm thinking particularly remote and rural communities, also in low resource countries if we're thinking broadly. Obviously, we're not able to do a full physical exam like in virtual AD. I can't take a listen to their chest, or even looking at a rash has been difficult with can be difficult. There's sometimes loss of nonverbal communication. There also we've been raised some concerns about privacy, confidentiality, particularly if you're doing a consultation in a household where there may be some family violence or elder abuse. And there has been concerns raised by clinicians that they might be secretly recorded. And then there are obvious barriers to access for vulnerable populations for whom video technology can be a challenge. So elderly groups such as like my parents, who are not necessarily techno savvy, low English proficiency groups, or low socioeconomic groups who may not have the technology available. Although it seems like everyone seems to have an iPad or a phone available these days. So let's see. Yes, and then obviously this is the CrowdStrike that happened, I think 2 or 3 months ago, where everything went down. Obviously, these systems are quite vulnerable to that. But there are multiple papers. The evidence is really showing that telemedicine is really providing quite a number of social, financial, and environmental benefits, all three things which you need for sustainable healthcare. So particularly the social benefits, increased access to healthcare, particularly again in those rural or remote areas or areas of provider shortage, but also here in urban areas where there's a lack of good public transportation infrastructure, or patients who are chronically ill, those with mobility issues, maybe those with some oxygen, oxygen cylinders, or, whom are in wheelchairs and moving, commuting in for an appointment can be difficult. Obviously, there's some reduced infection risk by using telemedicine, particularly during COVID, but even now with like flu. Obviously, time and cost savings for patients. So there was a paper that talked about the average appointment, the time for the patient for the appointment itself. It averages about 5 hours by the time you drive in, by the time you find parking and you register, and then you just sit there in the waiting room. So an average of 5 minutes, and then there's less disruption to employment and other daily activities. So there was an average of at least 9 hours saved by doing telemedicine instead of coming in to an appointment. And the average cost to a patient is at least $250 to $350 plus per visit, depending on how far you need to come, how much employment you've had to lose, and those sorts of things. There is also the benefit of staying within the home environment, particularly with hospital in the home versus being in-house. And still we're finding some pretty high patient satisfaction. In surveys, they show that it may be marginally less satisfied than a face-to-face appointment, but overall, it really has shown to be fairly non-inferior to a face-to-face visit. And what we found is that the further away a patient lives from specialist care, particularly in those rural, remote areas, the higher their satisfaction with telemedicine. And then there are obviously the financial benefits, the cost for the patient, the cost of petrol, the cost of missed work, but also to the healthcare system. So what they've found is the health systems that benefit most from the financially are those who fund clinician travel. So those health systems that have outreach clinics. So like we send our clinicians out to Mildura, or they send them out to, Shepparton for those rural clinics. So that's where it can be very cost saving for a health system. Obviously, with virtual ED, we're hoping that we are decreasing actual physical ED visits. With hospital and home, we see fewer hospital bed occupied bed days, and we can move into in-home monitoring. There's multiple studies that have shown a decreased failure to attend rate in outpatient clinics. And with the decrease in outpatient with failure to attend rates, we also show that we can care for more patients because actually the appointments with telemedicine are shorter, and so you can go through more patients. There are other studies that show that having a telemedicine program can actually increase the costs a little bit to a health service, but then you get increased clinical effectiveness and a higher quality adjusted life years. You can see more patients and care for more patients. So for a health system, oftentimes there is a significant cost saving. But I do need to point out that oftentimes to the wider healthcare system, like Medicare, the costs might be higher because of increased patient throughput that Medicare is paying out, a greater accessibility for patients, and greater convenience for patients. And that has potential for excess use or abuse. So it may not save the wider healthcare system some costs, or you may have an overall healthier population in the long term. And then, and then there are the environmental benefits. We know that the carbon footprint of travel in particular, of patient and staff travel into a hospital makes up about 10 to 15% of the total healthcare carbon footprint. There have been many studies that have looked at comparing an in-person visit with a telehealth visit, and they've actually calculated the energy use of video equipment. So here, the video equipment is basically 40 to 80, 0.4 to 0.8 kilograms of CO2 per 1 hour video consultation, 1 hour consultation, with the video being higher than the telephone. There have been multiple studies that have shown, compared to an in-person visit, there's a savings of anywhere between 0.7 and 372 kilograms of CO2. I've seen that number even go up to like 600, 700 kilograms of CO2 per consultation, depending on how far people have to travel. And in total, you do get a CO2 reduction in greenhouse emissions by anywhere between 95 to 99%. And that is mostly all in travel. As you can see in this slide, it's all the CO2, most of the CO2 comes in from transport. So if you look at the life cycle analysis, initially it looks actually quite good. So as you can see here, an in-person clinic visit, the life cycle analysis, you take into account the patient transport, and then also the facilities, the lights, and the airflow, and the equipment, the PPE that's used, and the other consumables. And you compare that to a virtual visit where the patient and the clinician stays home. You still need that energy to run all the computers and things like that. But the life cycle, this is still a fairly simplistic view. So you have to, and it's still quite wiggly, because the equation depends on, how much is the energy coming from a green source, renewable resources. We know on this side that the cars are becoming more energy efficient. Like if you're transitioning to EVs, maybe this footprint won't be as high. And then we have to start thinking about virtual visits. How often is it not a successful visit? And whether there are downstream effects, like whether a patient needs to come in to a GP clinic or an ED anyways, because they can't be fully evaluated on virtual. So we do have to take into account that maybe they do need to be seen after a virtual visit, or they may need to go out of their house anyways and get some bloods done. So current life cycle analyses aren't taking all of that, haven't taken that into account yet, those sort of flow-on effects. There's also the flow-on effects of, decreasing air pollution by not driving. And how far do you take that life cycle analysis? So that's sort of something to consider for the moment. Yeah, so oops, I'll get rid of this slide. So yes, so and then there are the risks and unintended consequences. So um, do we feel that it is as clinically effective, and does it compromise quality of care? So the lack of the physical exam, harder to do pathology or radiology, and again, the need for downstream visits. Do they present sicker or need more intensive care than if they were seen face to face for the first time? And then there's concerns about, it's been raised by rural and remote health services that maybe it might lead to a decreased health investment in both in their infrastructure, because people are relying on telehealth for more for healthcare delivery. So there is, in terms of the considerations for pathology radiology, we know that acute care often needs more investigations than chronic conditions. In a GP's office, they've noticed that that if the referral for tests is about 10% of consultations for GP if it's done face to face, versus about half of that if the consultation is done over telehealth. So there are kind of fewer bloods being done, fewer urines. It's harder to do a chest X-ray, those sorts of things. But is that really, that's something to think about? Is this really substandard care, or are we actually becoming more judicious in what we're ordering? And I think I really need to show you, I guess I'll point out these two studies. There have been a few systematic reviews that have actually shown that there is no difference between telehealth and face-to-face visits with regard to needing escalation of care to the ED, more hospitalizations, death, or adverse events. All right. So I think so far the studies are showing that that it's actually pretty comparable in terms of clinical outcomes compared to face-to-face visits. So I'll talk very briefly about virtual ED because I want to save time for questions. So I am a pediatrician on virtual ED. This is data from Australia stating that all over 1 in 3 ED presentations, 35%, are classified as low urgency. So category 4, category 5 presentations in the ED. So already in the ED is being overwhelmed by a lot of these presentations that might not necessarily need to be there. So 35% are filling up the ED. And so we're trying to figure out whether virtual ED can kind of take that load off of the physical EDs. So you can see, you know, obviously the ambulance ramping issues and patients and the overwhelmed EDs that we've been seeing. So in virtual ED, let me see. So just to tell you about virtual ED, patients can either call in directly and have a consultation, or we are also helping urgent care centers in the remote areas. So like in Kyneton, in Orbost, Stall, Horsham, all of them have like urgent care centers, and oftentimes they're often don't have a GP there, and they're calling into us, and we're trying to help them keep patients there rather than driving 2 hours to Wangaratta or to, you know, Mildura or whatever. And if we can keep as many people at the urgent care centers as possible, then that's helpful. We also provide backup to Ambulance Victoria if they feel that they can keep a patient home and not take them into the ED. We will help them make that decision as well. So yes, there's a patient self-referral pathway, and then there's the pathway from other healthcare providers. So AV, these are the aged care facilities or like urgent cares as well. And so we're seeing all those patients. So just to show you how virtual ED has grown and grown and grown through Victoria. It really started in 2020, late 2020, as a result of COVID. and has just really just expanded out. And we just cover all of Victoria now. We also help with the border towns as well, like Albury, Wodonga, and Echuca and Mildura, and also a bit of Tassie as well. Just to give you an idea of how many we see. So the average daily volume, this is back in June of this year, this is peak influenza. We were seeing about 800 patients a day. About a third of them are pediatrics, and a third are 18 to 60, and about, 30% are above 65. Our diversion rate from, or what percentage that we keep at home or to a GP or urgent care or away from the ED is about, we keep about 85% home and send in about 15%. And we've seen a positive, very positive patient experience here. And then in terms of patient outcomes, of the 85-ish or 85-ish that we actually are able to keep home, the most recent study shows that only about 6% of these patients will present to a physical ED within 48 hours of us seeing them. And so that is actually in line with the representation rates in a physical ED. So representation rates in a physical ED such as ours would be 3 to 7%. So virtual ED, we feel, is from a quality measure doing about the same. Obviously, there's more work that needs to be done to really tease this all apart. And that's part of what I am going to try and do, is looking at the environmental footprint of this, plus seeing what we're saving. I do think with virtual ED, we are seeing a lot of GP presentations that are coming into us, because there's so many people out there saying, I can't get into a GP. It's a week before I can get an appointment. And so we have become sort of a GP service as well, a little bit. But I do think, particularly during flu season, I think we saved a lot of people from going in. There's a few specific clinical conditions that we can be very helpful for, because we can prescribe as well. So things like gastro, where we can give some antiemetics and we can actually monitor them over the next couple hours and just make sure that they're starting to drink and stuff. That's one ED visit averted, things like that. So yeah, and then virtual ED is now starting to expand to outpatient clinics. So there's a range, there's probably 20 different outpatient clinics now that are being done over virtual ED. It's called, it's branch of specialist consults instead. And this will be particularly helpful for rural and regional patients where they can't get into specialists easily. So I think that's where I'm going to conclude. I think right now there are significant social, financial, environmental savings for patients using, in general, telehealth models of healthcare delivery. Certainly for a healthcare system, improved access, increased efficiency, and therefore patient capacity, certainly less travel for the healthcare system as well, not just for patients. And in long term, maybe cost saving, maybe cost neutral, and maybe a little bit more costly, but hopefully better outcomes. Certainly depends on context. Like, you know, whether this is a first-time visit versus a review visit, whether it's an acute context versus a chronic condition. So I think that's where the research really needs to come, where we can be a bit more selective in how we use telemedicine. Is it better for specific patients or specific clinics, acute or chronic conditions? I think there's a lot of research that needs to be done about looking at the full clinical pathway, and that and seeing these patients out to the end, whether they need to represent to an ED or not, or whether we need to send them to drive out to get investigations. So I think going out further with our life cycle analysis. And then there needs to be some research on how to increase access, particularly for those with low English proficiency or low access to technology. So, all right, so there you go. I will stop there. and we'll welcome any questions.
Thanks, Karen. That was a fantastic presentation, and it has been an interesting evolution of healthcare since COVID, isn't it?
Yes.
We've looked at that in the adult population in surgical outpatients, and there's certainly a cost saving and actually an improvement in staff and patient satisfaction with telehealth, particularly in Victoria, where so many of our hospitals have engagements with regional hospitals, isn't it?
Yep.
I think we've got time for just one question because we've got a couple more presentations today. Has anyone like to ask Karen about her work? I'll just check the chat. Ben Dunn from RMH.
Thanks, Karen. Really great. Very impressive work, and good to see how well the system seems to be performing. It's certainly safe and satisfactory to the patients. But seeing as you've noticed that you've started to see more people, that have come to you rather than going to their primary care kind of service, is there a thought towards actually expanding into that space, knowing that the primary care sector is already under a lot of pressure? GPs are very overworked, and patients are finding it hard to get in there. So it's sort of intentionally moving into that space.
I don't think right now that we're intentionally moving. I think we're just trying to develop the specialist clinics the way it is. Maybe in the future. I think the one criticism that we have in terms of moving into the space is it does disrupt the relationship with their own GP. Sometimes it can fragment care, and so that's not something that we want to do. So we need to be quite deliberate with it, and obviously get the GPs on board. So you're right, talking with our ICGP, and but right now I don't think there's actual plans. We don't want to take over the space of the GP for this necessarily.
Okay, thank you very much, Karen, and thank you again for your time this afternoon. I'm going to hand the floor now to Eugenie Kayak. Eugenie is our Enterprise Sustainability Professor at Melbourne University, and she's just going to give us a brief outline of what Melbourne Uni is going to be doing in this space. Thanks, Eugenie.
Well, thank you very much. And thank you, Michael. I just wanted to actually say a few words in the middle, just to really a special thanks also to you, Michael, and St Vincent's Health Australia for hosting these quarterly University of Melbourne Sustainable Health Grand Rounds over the last year. It's been a great initiative, and we've really been honoured, I think, to have such calibre as speakers like Karen Keehan and Monique Ryan, I'm sure, to follow, as well as, if we remember back to the beginning of the year, the Director of the Climate Health Victoria Unit, Heidi Makovic, and also the Deputy Director of the Federal National Health and Sustainability and Climate Unit, Alice McGushan, just to mention a few over the year. So I think as 2024 comes racing to an end, I'd also like to highlight some of the significant developments within the university concerning sustainable healthcare and our expertise and capacity over the last 2 years, because it has been quite extraordinary. In addition to my appointment in the medical school and the Department of Critical Care, and also the lead of sustainable healthcare for the Climate Catch Lab, we also have an Associate Dean in Sustainable Healthcare now, who I see is online, Associate Professor Forbes McGain, who leads our sustainable healthcare work across the Faculty of Medicine, Dentistry and Health Sciences, and also leads a relatively newly launched Healthcare Carbon Lab. And I think both he and I are really fortunate to have a growing team of sustainable healthcare people at the universities, such as Scott McAllister and Catherine O'Shea, Rebecca Patrick, Sonia Chantelanti, and Ben Dunn. I'd like to just put a call out to Ben, who was online and has really been helping with many things, including these sustainable healthcare grand rounds. So look us up. I'm not going to put a QR code up, but if you look up the Climate Catch Lab or the Healthcare Carbon Lab or the Department of Critical Care, there are direct links to some of our sustainable healthcare work. And thank you. Back over to you.
Thanks, Eugenie, and it's really fantastic that the university is getting so involved in this space. And Forbes knows this, but this whole meeting actually started because of a presentation Forbes gave us in 2020, I think, at our St Vincent Surgical Forum. So it's sort of nice to complete the circle, I guess. So that brings us to our second speaker, and I think Monique will be very, very comfortable speaking to this health audience. And I'm excited to be able to say, it might be wrong, but I'm excited to be able to say the Honourable Professor Monique Ryan. Is that the right title? It sounds
No,
weird.
no, I'm not honourable. Unfortunately, you only get to be honourable when you've been a minister.
Oh, well, it sounded good anyway.
It does sound good.
Professor
Well done.
Monique Ryan was elected to the federal seat of Kooyong in May 2022, the first woman and the first independent to hold the seat. She was formerly director of the Royal Children's Hospital Melbourne Neurology Department and a professor of medicine at Melbourne and Monash Universities. Dr. Ryan is committed to action on climate change, integrity and transparency in government, evidence-based healthcare and gender equity. I know she's in Kooyong because I ran into her at the Glenferrie Festival last year, so I know she's a real grassroots politician, and I'm really excited about the changes that she's been able to implement, and very excited to hear her talk about top-down and bottom-up, why we need to tackle sustainability at every level. Thanks, Monique.
Oh, thank you. And lovely to bear with you all today. I don't have any slides, I'm afraid. And I don't really have so much as a talk, basically, as a call to arms and a plea. So, I think everyone who's on this call today has an interest in sustainability and in climate action. Many of you will know the science of it better than I do. I was never a climate scientist before I became a politician, but I was someone who, like I'm sure most of you, became very aware over time of the progressive nature of climate change, its clear and obvious effect on climate and environment already globally, and the fact that when globally as well, we're not acting as quickly and effectively as we need to remedy it and reverse the impacts that we've already seen, much less prevent the increasing impact over time. So it's an interesting thing to become a politician and try to have an impact on that. I'm really keen to have questions and answer Q&A at the end if we have time. What I've found is that most people know that we need to do something. Many people feel a bit paralysed by the feeling that their own sphere of influence is so small that it's of no significance. Having said that, we all save our soft plastics and things like that and then get frustrated when we can't recycle them. But really feel that many of us feel that we can't really have an influence of any significance whatsoever. So in many cases, people say, why bother? And every day, I guess, when I go out into my electorate, I hear people say, well, why should we do anything? Australia's such a small player on the world stage. It's all up to China and the UK and the US to do what you can. But the reality is that the changes that we all make within our own sphere of influence are obviously cumulatively quite significant, but they also play into our own mental health and our relationship with our families and our patients and how we feel about ourselves and present ourselves to the world. So what I found as a politician is what I can best do is be a conduit for other people's expertise and knowledge and try to communicate it to the people that I represent, but then also try to communicate it at a national level in a way that will bring people together, firstly in a recognition of the reality and the significance of climate change, but then secondly in a way that can constructively hopefully approach it and try to address it. So there's this, I'm not sure if what you've talked about in these grand rounds before. Most recently, the way that I've tried to act in that fashion has been in concert with people like Karen and people from the Doctors for the Environment Australia and the Climate and Health Alliance, also the Australian Indigenous Doctors Association and some building groups and a sustainable development group from Monash. And what we did was put together a proposal for the government for a trial of 9 site-specific feasibility studies for electrification of hospitals. And the idea is that the existing hospitals would be subjected to a retrofitting program. And there was in Victoria, we had 2 sites. One was Echuca and one was at Caulfield. And the idea was that we would undertake this trial of retrofitting of those hospitals to have a look at the extent to which that was possible, the costs involved, and then the savings for the hospitals in terms of their energy requirements and also in terms of energy reductions. And the idea was that that would form a model for nationwide adaptation. So this group of people came together, approached a number of parliamentarians, as is often the case. The ones who were interested in taking it up as a cause and taking it to the parliament turned out to be crossbenchers. There were three of us. Helen Haynes, who's many of you will know, is from Indi in regional Victoria. She has a PhD in nursing. Sophie Scomps, who's a GP, and me, and we've basically presented with the Healthy Futures Alliance, we've presented this proposal to the government and asked them to consider it for their March 25 budget. It's now looking increasingly likely that there won't be a March 25 budget, because I suspect we might come to an election before the end of March of next year. But it was an interesting initiative and something that was good to work on with the doctors' groups involved. And I guess one of the things I would like to say to all of you is that if you have initiatives like that, which are focused, discrete, and when I say discrete, I mean relatively circumscribed in their size or their scope, things which are essentially are doable, and things which will have a potentially significant impact, that if you have those sorts of things or those sorts of concepts, I think that I can speak for myself, but also other crossbenchers, and that would love to hear from you and work with you on them. What we find, those of us on the crossbench, we have very small teams and we're overwhelmed with people coming to us with good things that we could do and they would like us to do. I had 7 constituent meetings this morning of 15 minutes each, and 7 good ideas that people brought to me and that they wanted me to think about, talk about and work on. So, and it's not possible to take up all of those. So you have to pick your winners. But what makes something a winner is the fact that it is doable, that it can be seen to have a significant effect on something which is important, that the timeframes are sort of reasonable, and it's something that someone like me can pick up and push as an issue, either by myself or with other members of the crossbench. And so I'm kind of here not only just to talk to people and see if anyone's got any questions about how things are working in Parliament with the crossbench and what we're trying to do on climate and environment, but also as a bit of a plea to all of you. What I have found in the last 2.5 years is that I've been very much reliant on the kindness of strangers, but the strangers have been very kind. And so I found that regardless of what issue I'm trying to work on, if I pick up the phone and I call experts, once I work out who those experts are in each area, people tend to be very generous with their knowledge and their expertise generally. And I think the other crossbenchers find the same thing, generally because we're trying to do the right thing and we're just trying to get up to speed with, complex pieces of policy, sometimes very quickly. And people know that if they give us the benefit of their knowledge and their expertise, then, hopefully we have better outcomes as a country. So I'm going to stop there, but really keen for people's thoughts, questions and suggestions if you do have any.
Fantastic, and thanks, Monique. I'm sure there will be plenty of questions. So whilst people get on, I'll just ask, when you do go to Canberra, and Australia historically maybe described as a little bit of a laggard in this space, what do you feel the appetite is there amongst your colleagues, and do you think it's sort of just lip service, or do you think we're really slowly moving as a government towards kind of more investment in this space?
Well, I think that it's a game of two halves. The half on the right, the opposition, are not really truly committed to action on climate change or the environment. Even yesterday, I think Bridget McKenzie, who's a national senator, said, yes, of course, we're committed to net zero by 2050. And on the same day, Matt Canavan, another national senator, tweeted net zero by 2050 is dead. So, they are internally unconvinced and not committed. And the opposition will say what it needs to say at the time of elections to try and bring people along. But I don't believe it. I don't think it really believes it. It seems like it's a half-baked, half-assed nuclear policy is really just an excuse for continuing its support of oil and gas. So it's not committed. The Labor side of things, the progressive side of things is committed, but when we pass lots of legislation which have been climate and environment related in this parliamentary term, but that each piece gets watered down. Yeah, sometimes things start looking quite good, and then they get watered down by the time they get passed by the Parliament, either in the House or in the Senate. Or we get things where we just think, well, what is the point of that? It's too small a target. It's not. There's one case where big targets are a good thing. So I would give the Albanese government a C+, maybe a C, for what it's done on climate and environment. We've had some massive pieces of legislation that have basically gotten stuck and haven't moved through, like the Environmental Protection and Biodiversity Conservation Act, the EPBC Act, which they split into 3 parts, and the second part is stuck, and there's no sign of the third part, and they had promised us that massive piece of legislation would get through. If it doesn't get through and there's a Dutton government, God only knows what's going to happen to our environmental protections after next year. So that's been frustrating. And then you've got the Greens who tend to get bogged down in letting perfect be the enemy of good. And I find them frustrating to deal with, because very often they'll hold out for the perfect result and then we don't get any result at all. And then you've got members of the crossbench, and we are not a homogeneous group. The so-called Teals who were elected at the last election, we're all pretty strong on where we feel on climate and environment. Some of the others much less so. So it's not we're all over the place a bit. And I've been quite open about the fact that I'm hoping for a minority government next time with a crossbench that is climate committed, having the balance of power, because I think that would be the best thing for the country in terms of its action on climate and environment.
Thank you. Forbes.
Thank you very much, Monique, Ryan, for a fantastic talk. You talk about focus things. I was thinking something that Doctors for Environment Australia, as well as other groups, have been very keen on. We're moving now, like in Victoria, for example, there won't be any new houses built with gas. And that's really exciting. We've also, there are a few hospitals in Australia, the new Canberra Hospital, the Women's and Children's in Adelaide, and the idea is that the new Melton Hospital in Victoria will not have any gas, because basically about a half of all energy for hospitals is actually for gas. The other half is electricity. So even if you're 100% renewable electricity, you've still got half the energy source is gas. So I just wonder, is that the sort of thing that where at the federal level where there could be some influence as well, that really we just don't want any more hospitals in Australia, new hospitals built on gas at all? And it's something where we have a focus as doctors, nurses and other clinicians. Is that something, we can work with you and other like-minded folk at the federal level as well as the state level? Is that focused enough? Because you talked about focus things there.
Yeah, it's an interesting question, Forbes. I think people do know that, I think I was looking at the figures for the Royal Children's, and it's about half gas, half electricity in terms of its power usage. I guess the complexity there is that the hospitals tend to be built by the states, but obviously much of the funding in many instances would be coming from the federal government. So that's, I guess, where the rub would be, that we would hope that any funding that was allocated by the federal government would only be to buildings that met certain criteria in terms of their design and their specifications, that being that they should be powered by 100% renewable. I'm trying to work out how that would happen, because those sorts of big picture funding allocations to the states would usually be in the budget. And it seems like a weird thing, but it's one of the weird rules that you come across when you become a parliamentarian, is that there's certain pieces of legislation that can be moved by different people. So I can't move, as a crossbencher, I can't move a private member's bill or something like that that has to do with funding allocations. So I couldn't, even if I, and if I did, the government wouldn't accept it anyway, because they'd be telling me that, I can keep to my knitting and not tell them what to do with their money. But I think I certainly agree with you. I was talking to someone about this today, about the SRL roads link in Victoria, that we should have, that there should be restrictions about any large level funding. I think any significant funding allocations that come from the federal government above a certain level, whether it be maybe 3 or 4 billion, something like that, where, you know, everything has to go to Infrastructure Australia, and then you have to say, well, Infrastructure Australia has to tick off on everything based on the specifications, you know, one of which would be that it's not reliant on gas or oil. You know, having said that, in my in the suburb in which I live, I've been fighting with the council for 2 years because they're about to build a brand new pool that is supposed to have a gas hot water heater. You know, it makes no sense, but it's an ongoing fight. I agree with you with the underlying premise, though. It's, you know, the other thing, quite apart from anything we keep saying to people, the gas is expensive now. It's going to get more expensive. You know, from a purely economic viewpoint, you should be going with what's going to be cheaper, which is going to be electricity via renewable sources.
Thank you.
Michael Loftus. Mike.
Thanks, Michael, and thanks, Monique. I'm an infectious diseases physician dialing in from Kooyong, so a local constituent. I guess, zooming out a little bit, I guess I wanted to take you back to Canberra and just get your thoughts on the debate and the climate debate that we have in Australia, and the role you see for healthcare professionals and how successful we have or haven't been in inserting health into the climate debate. And I guess whether that is going to be a successful lens, or those who want to delay and put it off will say, well, you know, it depends on the US and others anyway. Or what can we be doing as healthcare workers, healthcare professionals, helping people see the broader impacts of climate change, and how successful otherwise do you think we've been from your perspective in Canberra?
Thank you. So it's a good one. So we've had, I think, health professionals have had some success, but it's been a bit limited, and there's a reason for that. So one of the things I did was there's a whole group of medical professionals, doctors, but also vets and other medical professionals who came down from the Northern Territory at one point, and they were basically protesting the Middle Arm gas development in Darwin Harbour, but also the fracking of the Beetaloo Basin, and they were doing that on the basis of the health concerns related to that, and it was impactful. Actually, it was really impactful, and we had a really large group of people who came, got a reasonable amount of media, and I think people heard, because people actually, politicians believe real people like doctors and nurses and vets and things like that more than they do each other. So when a big group of people like that comes into the House, it is powerful. Having said that, we haven't shifted the dial on that particular issue successfully, although the environmental minister, Tony Plibersek, after a lot of pressure, has sort of put off some of the Beetaloo approvals until what will almost certainly be after the next election. So she has paused things to some extent, but we haven't had any sort of firm success. There's probably a couple of reasons for that. The first is that we haven't managed to keep the pressure up to the extent that we need to. I've learned this year that in the last 2 years that you have to just keep putting the pressure up and banging on and on and on and on about an issue. A lot of people have no idea what Middle Arm is, and it seems like a weird, you know, third body part, and they also don't understand what the Beetaloo Basin is. And anything that happens in the Territory, even though we all breathe the same air, seems very distant to people. So even in Kooyong, which is a well-educated, knowledgeable electorate, if I go out and talk to people about this, a lot of people are like, I have no idea what Middle Arm is, I have no idea what Beetaloo is. So it's a bit of a hard sell, and it's tough for those doctors to keep the pressure up because it's a long way to come and a real disruption to their work practice. The other thing that has really stood in the way of the doctors and the health aspects of climate change, and it's basically applies to other aspects of climate action as well in the last 2.5 years, is that people are just really, they've got the blinders on about the cost of living crisis. And so when you talk to people about renewable energy or other sorts of, you know, rolling out of electrification, all that sort of stuff, people are, yeah, but I can't afford to pay my electricity bill, and it's getting more expensive, and my groceries are getting more expensive, and you're telling me that I should replace my gas cooktop. I haven't got the money for that, and it's not front of mind when I'm struggling to pay the rent or the mortgage. So the cost of living crisis has sort of sucked the oxygen out of lots of other aspects. But I don't think it's a reason to stop trying, because people do respond to the health side of things very much, and they do trust doctors much more than they trust politicians. So some of those doctors from the Territory are coming back to the House in a couple of weeks, and we're going to be pushing the clean air side of things. We're going to be pushing, you know, some information that we've got about the impact of fracking and potentially the middle arm development as well on the air quality in the territory, and extrapolating that to other states and territories as well. If I had another 5 or 6 policy people, it's the sort of thing that you could work on it from coming at from different angles all of the time. But we struggle, and it's the same with the guys from the NT, that we just struggle with giving it the time and that it deserves, and keeping it front of mind for people as much as it should be.
Thank you, Eugenie.
Yep. Hi, and hello, Monique. Thank you for taking the time
Nice
to
to see.
speak. Also coming in from Kooyong, dare I say it. We've sort of like sustainable healthcare, and we've talked about energy, and I think many of us know about the carbon footprint of our practices, but the first principle of sustainable healthcare is actually prevention. And I was wondering what your reflections were on how we can elevate the importance of prevention, because it's, it's just has a very small amount of the health budget. And it seems that politicians don't have that sort of forward thinking when it comes to the amount that you put into it, how much it will actually save the community and the health care budget into the future. It just seems to be forgotten to a degree.
Oh, look, it definitely is. And politicians have very short attention spans, which are at absolute maximum of, at this point, 3 years. So it's just absolutely remarkable how little forward planning there is about all aspects of important policy in this country. But health is just one. People can't think about tax or education or disability or all these other things in more than 1 or maybe 2, if you absolute maximum 3 electoral cycles. But I think the way to do it is that twofold. I'd actually hoped that there'd be much more progress on the CDC in this parliamentary term, and that it would include a significant component of action on things like chronic disease and preventable strategies for prevention of progression of chronic disease. It was also obviously supposed to include significant a significant body working on climate action as well. There's been very little progress on it, obviously, to date, like very little. And I know we have a promise of that in the next budget, but, when will that be? So that, I think the CDC is possibly where we might get a little bit more commitment to more quality long-term planning and policy making for preventative health strategies in Australia. The other thing would be, I think we need significant reform of our Medicare funding model, such that, if we have a mixed model where people don't just get paid for seeing patients when they're sick, but rather get paid for seeing them, keeping them well, then preventative health will become much more front of mind for people on a daily basis. So I do think that we do need to, that's obviously another long-term, bigger picture issue, but I don't think that our Medicare is set up to support preventative healthcare very well. I don't think it's just a question of giving people a rebate for seeing people for health checks or that sort of thing. I think we actually do just need to completely restructure how GP practice in particular works. But again, that's a matter for a second or third term of this government if they get that. I have talked to Mark Butler about it, and he gets it. He understands the need, but I don't think he has quite the vision in place just yet.
Thanks. We might have the final question from Associate Professor Chris Leong from the Austin.
Oh, yeah, thanks, Mike, and hi, Monique.
Hi, Chris.
Thanks for opening our Chinese Medical Association house on the weekend in Kooyong.
It was good to see you.
Good.
I'm just loving the fact that every single one of you seems to be from Kooyong. It's fantastic.
It's a great electorate. So I was going to ask about choosing wisely, because I love your comments about low-hanging fruit, and certainly in Victoria, the Choosing Wisely and Scaling Collaborative that's Austin Health led and across 11 health services, dramatic results in terms of decreasing low-value care, which accounts for 40% of our clinical care and 40% of our carbon footprint in terms of healthcare. And within 4 months, we were able to decrease a lot across 11 health services, 33% of unnecessary, even harmful care. So rebranding that, I guess, I know it lost its funding previously. It used to be very well funded, and the results showed. The thing about Choosing Wisely is that the lesson we learned was that it needed ongoing sort of resourcing to ensure that every new intern, every new registrar has that sort of mindset and continues to get feedback about that. And I was wondering, has there been conversations at that level about perhaps reinstating some of that funding for Choosing Wisely nationwide? Because in terms of low-hanging fruit and rapid climate action, it does have that potential to really decrease our carbon footprint. So I thought I'd take that opportunity to ask in case you haven't heard. Thanks.
Yeah, thank you. I haven't heard, and it's a really good question. And I'd be very happy to follow up on it. If someone were able to just send me a 1 or 2 pager with, a summary of what you have, the history of the program, what it was demonstrated to do, and where things are, I could certainly follow up on that for you. I have not heard anything. It's not been mentioned at all.
Return of investment within the year, so that's not a great thing about it.
Yeah, great. Okay, we should talk.
Yeah, absolutely.
Thank you.
But Chris, it now sits under, doesn't it? Sorry,
yes.
The Australian Commission of Safety
Correct,
and Quality for Healthcare. Yeah.
Yes. So hopefully we can have inroads that way. Obviously, the broader the messaging sort of message gets out there, the better, I guess, because it is something that a lot of doctors and clinicians are very passionate about.
Yeah, so, absolutely. Yeah.
Right, thanks, Chris. So, Monique, I might just ask you to give one final comment. It's interesting, I guess you've been in both situations. You've been a passionate environmental warrior like we all are, but now you're also, in the seats of power. What advice would you give to people like us who are very good at acting locally but would like to broaden our impact? Is there anything we can do to help people like you?
Well, as I said earlier, a lot of people come to me with ideas and things that things that they feel passionately about that they'd really like action on. Basically, it's a question because people like me are very time poor and have lots of these competing, all very worthwhile sorts of things are landing on our desks. Anything that you can give us which is relatively small and discrete package. It's not that we're not able to take on complex stuff. It's just that we just struggle with the breadth of the information and the number of different things that we've got on our plate at any point in time. So small packages of information, 3 or 4 page briefers with basically a call to action at the end that tells me what I need to do, how that might work, and then harass us incessantly until we actually respond. Because there is a lot of noise going on all the time and competing demands on our time and attention. So it's not always easy. Even when you know something's really important, it's easy to forget it, put it aside, and neglect to come back to it.
Thanks, Monique. Thanks for your time today, and thank you also for your voice and advocacy. And I think you've certainly solidified a few fan people here in your seat today. So I'll bring this meeting to a close. This is our final Melbourne Uni Grand Round for the year, and also our final St Vincent's Grand Round for the year. We'll reconvene in the new year, probably in February, and before then I'll try and send some communication around to the whole group, trying to just hone how we do this to try and make it as useful and as practical and at the best time for everyone, bearing in mind we do have a very wide audience, not just medical staff, but we'll try and capture as much of the hospital as possible. Thanks to Jenny for supporting us, and all the speakers over the year. And please, if you have any comments or suggestions, please reach out to me. So thanks very much, Karen and Monique, and I'll call the meeting to a close.
Thanks, everyone. It was fun.
Thanks all. Thanks, Michael.
Thank you. Bye.